Gerald's a true leader in cardiovascular anesthesiology and critical care. Goes way back. He has a tremendous experience. He's written extensively. He directs research projects. All I can say is that we are very fortunate to have him talk about cardiovascular pharmacologic support. Gerald, pleasure to have you.
I'd like to thank Dr. Kotz and Dr. Mulligan for the kind invite to come back and present this area. What I'm going to talk about is what we do every day, is managing biventricular dysfunction after cardiac surgery. I think this is a really important bread and butter of what we do, and we've done a lot of work in this area to try to look at novel and standard therapeutic approaches. So you've seen iterations of this slide in many different ways, but it's really what you and I do every day, is that you monitor and manipulate hemodynamic involvement with manipulating blood pressure. And although highly simplistically, remember blood pressure is a product of vascular resistance times cardiac output. So if you're hypertensive, which we'll talk about, you really have two options: modulate cardiac output. This is the after major aortic trauma in the hyperdynamic patient, where you want a sympathetic lysis of the patient with drugs like labetalol that are alpha-beta blockers or other pharmacologic interventions, or the cornerstone really is vasodilator therapy. But in the patient with biventricular dysfunction, cardiogenic shock, you have multiple options, specifically inotropes, mechanical assist device to monitor cardiac or manipulate cardiac output, or clearly in a patient who's in vasodilatory shock, the use of different vasoconstrictors. One of my sub-interests for over a quarter of a century is anaphylactic shock, so studying and understanding mediator-induced vasodilatory shock is really interesting and important, and we'll talk a little bit about that as well. So the basis of what we do every day in the cardiac surgical intensive care unit is we use pharmacologic therapies, specifically vasodilators for hypertension or biventricular dysfunction, inotropic agents, pulmonary vasodilators, and then there's some other interesting agents, which I'm really not going to talk so much about nasiratide, but I am going to talk a little bit about levosimendan, since there's renewed interest in this agent and to push it through in North America. A few caveats here. Of the agents we use for inotropic agents, the catecholamine and phosphodiesterase inhibitors will be the focus. Interestingly, thyroid hormone, my mentor when I was a medical resident years ago was a guy named Gerald Levy, who became the provost at UCLA, who did the work with Steve Epstein at NIH, showing that thyroid hormone increases cyclic AMP in the heart and drops vascular resistance. And despite enthusiasm about 10, 15 years ago for this agent, it's really fallen into disfavor as a therapeutic agent. So let's start with catecholamines. When you choose a catecholamine in your clinical practice or a combination, you pick a drug that has varying effects on alpha-1 receptors, which produce vasoconstriction, beta-1, which are inotropic and chronotropic, and beta-2 receptors. And the mainstays that we use mostly in our setting is dopamine, norepi, and epinephrine, as well as potentially phenylephrine. Interestingly, there's a shortage of norepinephrine as well as shortages of other drugs, which has created somewhat of a perplexing phenomenon of what to do, especially if you use a lot of norepinephrine. Interestingly, Michael Bristow and the heart failure gurus have shown that dopamine in the heart and the sympathetic nervous system is the precursor for norepinephrine. So if you're in shock, and heart failure and cardiogenic shock is a form of shock, clearly one of the things that you have to realize is dopamine is an indirect acting agent that may not always be quite efficacious and may have some adverse outcomes, as we'll mention in a minute. So let's first talk about epinephrine. Epinephrine is one of the drugs used in ACLS, widely used in cardiac surgical patients, also in anaphylactic shock and CPR. It's a mixed agent. The beta-2 effects are interesting because they'll make your glucose go up, they produce caluresis, and they also, through a complex mechanism, produce a lactate acidemia or a lactatemia. And if you have this ununderstandable increase in lactate and everything else looks reasonable, think whether you're using a beta-2 agent like epinephrine, since that's important. And also using anaphylactic shock as a first-line agent. The beta-2 may be important. In that scenario, it's a bronchodilator and has some mild form of pulmonary vasodilation. Norepinephrine is used extensively in a lot of cardiac surgical centers. I wrote an editorial in the New England Journal about over a year ago on a study. Remember the old concept that Levophed leaves them dead, and what we all learned as some time in our career? The problem with norepinephrine and septic shock is you've got multi-inflammatory responses, the systemic inflammatory response of the sepsis, and whatever you use, you have potential for adverse outcomes. When you look at its applications, especially in heart surgery, there's no adverse effects. There's additive synergistic effects as combination therapy with milrinone, vasodilators, and in fact, the Canadian group many years ago popularized LNR, Levophed, and Regitine, or norepinephrine and phentolamine, as a beta-1 specific agent before dobutamine came out. Interestingly, in that New England Journal of Medicine study, which I'm showing you here from 2010, basically there was no increase in mortality and shock compared to dopamine. In fact, when dopamine was used in cardiogenic shock, it had a higher mortality, probably due to the tachycardia and a variety of other effects. In fact, when you look at all of the randomized studies, norepinephrine tends to be a relatively safe drug. And remember, it's what's in your sympathetic nervous system to increase ventricular dysfunction. Let's talk now about the phosphodiesterase inhibitors, which really have evolved as cornerstone therapies in managing biventricular dysfunction in the cardiac surgical intensive care unit. All of us used to use aminophylline. Aminophylline is an interesting drug because if you look at patients with COPD who got aminophylline, what would happen is that their FEV1 wouldn't improve that much, but symptomatically they improve, because you treat cor pulmonale. It's an adenosine antagonist. It's a bronchodilator for that reason as well. And it produces a consistent tachycardia because it increases conduction across the SA-AV node, as well as increasing catecholamine release. So aminophylline was one of the first agents we all learned to use. Those of you doing this a fair long time remember amrinone, which was subsequently replaced by milrinone, which I think were really important advances for their ability to produce increase in contractility. We'll mention that in a minute. And every day a heart surgeon puts papaverine in and around the internal mammary artery. Papaverine is a potent calcium channel blocker and phosphodiesterase inhibitor, and that's why it's such a great IMA dilator. It's one of the derivatives of opium, and that's why it's called papaverine, because papaveridum is the Latin word for opium. So when you use a drug like milrinone, remember what milrinone does. Unlike the beta-1 agents, which increase cyclic AMP, milrinone inhibits the breakdown of cyclic AMP, which is key to increasing contractility by augmenting calcium release from internal stores in the sarcoplasmic reticulum. What's very interesting is, and I'll show you, in the vasculature it has the opposite effect. Instead of releasing calcium, it sequesters calcium, and hence you get vasodilation. It's the great example of how this drug produces what's called inodilation, which was Lionel Opie's first coined term. It's an inodilator. The first report in the literature almost 28 years ago from the New England Journal about use of milrinone in heart failure illustrates some of the key hemodynamic effects of milrinone. When you load patients who've been on DIG and diuretics and multiple other therapies with heart failure, what you see is an increase in contractility as measured by dPDT, which is a load-dependent way of looking at contractility. But look at left ventricular end-diastolic pressure. It falls substantially. Milrinone is a very potent venodilator. Jim Bailey and I showed in CHEST about 15 years ago that these drugs sequester about 400 to 600 mils of volume in your capacitance bed. So when you acutely load with milrinone, you drop preload. Thus, you may produce abnormalities in hemodynamics. One of the things that we showed, like the chronic heart failure literature or acute heart failure, when you load with a 50 mic per kilo load and 0.5 mics per kilo per minute, you produce therapeutic levels that increase your hemodynamics cardiac index about 30%. An interesting study that I did with my echocardiography colleagues at Emory is what we did is we looked at patients who came off bypass who had ventricular dysfunction receiving catecholamines. And what we did is when you added milrinone at various doses, you increased cardiac index on top of the catecholamines, and when we looked at an echo-derived parameter of contractility, specifically velocity or of circumferential shortening, a derived hemodynamic parameter, that all the patients had an increase in their contractility compared to catecholamines alone. And this sort of additive effects of catecholamines, norepi, epi, dobutamine, and milrinone is something we use every day for biventricular dysfunction in the ICU. And I think there's very interesting data. This is our clinical data. Michael Bristow has shown this with enoxamone, as well as catecholamines in vitro muscle specimens. And I think it's what we do every day, what clinicians often refer to as balloon in a bottle. Of course, this is not new, but this is the data that I think supports its application. A drug that we don't have here, but a drug that's being used in Europe and that's going to probably be restudied in cardiac surgery is a very interesting drug called levosimendan. We did some early work with this in clinical studies. It is a calcium channel sensitizer, thus increases the affinity of the contractile elements for calcium. It also activates KATP channels, these potassium-dependent ATP channels, which basically produces vasodilation, but it also has an anti-ischemic effect. In other words, it produces ischemic preconditioning, and very, very interesting data in its applications. Basically, you also get vasodilation, a drug that was extensively studied in Europe. It was studied in a heart failure here in North America, which wasn't approved, but I think in the cardiac surgical arena, especially with its ability to modulate KATP channels, it's very interesting, and perhaps some of the Europeans in the room have experience with this drug. Markku Salmenperä, a friend of mine in Finland, did a lot of work with this, and again, it's going to be probably restudied in the US. Let's move on to the other aspects of catecholamines and other drugs, specifically vasoconstrictor effects to increase vascular resistance, especially in vasodilatory shock or hypotension. There are multiple physiologic and pathologic agents, which has been an interest of mine, specifically from understanding anaphylaxis and pulmonary hypertensive type of responses. But the pharmacologic agents you and I use are drugs that have alpha-1 adrenergic effects or drugs like vasopressin. Now, just to sort of from a different paradigm, when you use phenylephrine, methoxamine, norepi, epi, the alpha-1 adrenergic effects in vascular smooth muscle have a very different effect. They activate an enzymatic process called phospholipase C, which generates diacylglycerol and inositol triphosphate, which basically causes calcium release from vascular smooth muscle. This is a different mechanism that is not highly regulated as in the myocardium, and this is simplistically how these drugs produce vasoconstriction. Vasopressin, though, however, or arginine vasopressin, has a totally different mechanism of action, which initially was studied in CPR, subsequently for vasodilatory shock. Remember that vasopressin is normally released from our bodies. The V1 effects produce a complex vasoconstrictor response. We'll talk more about V2 effects in the next lecture because that's involved in hemostasis. But what happened was early on, the German investigators found that during CPR, that patients who survived out of hospital arrest had higher vasopressin levels and higher return of spontaneous circulation. The other names for vasopressin are ADH, antidiuretic hormone, or arginine vasopressin, and again, it's the endogenous mediator. What's thought to happen, especially in CPR, is that the V1 effects of vasopressin increase blood flow to the head. They work in spite of acidemia, which is critical in shock and CPR, and it may improve cerebral and coronary perfusion. Its applications in septic shock and vasodilatory shock after heart surgery are really interesting because it's thought that it may antagonize the pathologic mechanisms of vasodilation by inhibiting KATP channels and antagonizing what happens with cytokines when they activate endothelium. Dr. Landry at Columbia did a lot of this work, and there's a nice review article in 2001 in the New England Journal. Mehmet Oz and his colleagues, Michael Argenziano, did 2 of the pivotal studies. Basically, what they found specifically was in 145 patients who had vasodilatory shock, high index, mean less than 70. There were about 8% who met that criteria. And interestingly, what they found was that in this patient population with vasodilatory shock, they had lower endogenous vasopressin levels, and that's where the infusion rate of 0.01 basically units per minute sort of come from their particular work. Let's move on now to hypertensive issues. And hypertension, for those of you who practiced a long time, has really evolved in clinical practice. When I was a resident at Mass General, I remember in the severe aortic injuries where they were hyperdynamic despite nipride and other drugs, I'd use drugs like IV alpha-methyl dopa and other agents, trimethopam and other particular agents. Now it's a different era with all the IV vasoactive agents that we have, also for the management of patients who come to the operating room who are hypertensive. Part of the problem, I think, though, is that with JNC7 recommendations, the blood pressure should be about 120/80. Very few of our outside patients are ever really managed that tightly, which is a whole separate issue. But I think one of the areas where we particularly can focus on both postoperatively is the management of blood pressure. The cornerstone therapies I mentioned are beta blockers or vasodilators. Of the beta blockers used clinically, the agents that you and I have are all pretty much intravenous, which are pretty much esmolol, labetalol, or metoprolol. The advantage of labetalol, in my opinion, is that it's a drug you can either bolus. Every Q4 hours, you can give it as an infusion at 0.5 to 3 milligrams per minute, and then you can switch the patients to oral management. It makes it quite easy to manage these patients, and the same occurs with metoprolol. Esmolol is relatively expensive, a short-acting agent, and an agent that if you're worried about bronchospasm, heart block, or other issues may be a useful agent when you need to beta block a patient. This is work that actually came out of Johns Hopkins, Dr. Cass's group, that done a lot of neat work looking at insystolic pressure-volume relationships. What they did is using a volumetric catheter, taking patients at control and baseline and then giving them esmolol, you see a shift of the curve downwards to the right, which basically is a simplistic way of saying beta blockers decrease contractility, looking at insystolic pressure-volume relationships. And that's basically what they do. There probably is a ceiling effect, and when you have a severely hypertensive patient, you really need to focus on vasodilators, the cornerstone, in my opinion, of therapy. There are multiple agents used clinically, specifically in the parenteral administration. For the sake of time, I won't go through these, but I think the mainstay agents basically are the agents that produce ACE inhibition, such as enalaprolat, but an indirect acting agent. I would be careful with using these agents postoperatively because of all the contact activation and basically ability to generate kinin. Remember, ACE inhibitors prevent the conversion of angiotensin 1 to 2, but also inhibit bradykinin. And what happens in heart surgery and cardiopulmonary bypass, you get a lot of contact activation. Alpha-1 blockers have kind of fallen into disfavor. Dihydropyridines are interesting agents we'll talk about. Nitroglycerin, nitroprusside activate cyclic nucleotides. And nasiratide is an agent that's been used in heart failure but has come under a lot of scrutiny in recent years. To me, the cornerstone of therapeutic interventions is focusing on the vascular endothelium and vascular smooth muscle. This is an internal mammary artery. This is data that I published about 12 years ago in Circulation. We were trying to understand mechanistically some of the effects on vascular regulation. This brown layer here is the vascular endothelium that's been stained immunochemically for nitric oxide synthetase after heart surgery due to both mechanical causes as well as due to systemic causes. There may be multiple mechanisms for endothelial dysfunction. But when you use a therapeutic intervention for a vasodilator, basically what you're doing is activating one of several mechanisms. The calcium channel blockers block calcium entry and are arterial specific. The drugs like nitrates, nitroprusside, generate nitric oxide, which causes cyclic GMP formation and sequesters calcium. Drugs like prostaglandins increase cyclic A, also sequestering calcium. And the PD inhibitors, whether it's milrinone or sildenafil, inhibit the breakdown of these nucleotides. Basically, prostacyclin and sildenafil are used for pulmonary hypertension. Nipride, nitroglycerin used primarily for systemic hypertension as well as calcium channel blockers. Nitrates are used extensively. There is the problem of nitrate tolerance, and there's a lot of interesting literature why that occurs in our patients. We won't go into that, but suffice it to say, as little as 12 to 24 hours you're on nitrates, you have the potential for resistance. IV nitroglycerin, in my opinion, is a good venodilator and not a great antihypertensive agent. Remember that a lot of our patients uniquely become hypertensive. The characteristic hallmark of hypertension is arterial vasoconstriction with intravascular hypovolemia, and we create hypertension when we fast-track patients. In our cardiac vascular patient, We have arbitrary levels where we keep the blood pressure. There's a lot of vascular manipulation and also the potential for ischemia reperfusion injury. The mainstay agents that we use in 2011 are nitroglycerin, nitroprusside, IV dihydropyridines like nicardipine. I've talked about enalaprilate. Hydralazine, a relatively weak agent, but used often when you're trying to wean off IV therapies, and nisiratide primarily used for heart failure. The NAPA data is very interesting, but it's an expensive therapy. Nipride, in my opinion, is an example of a pharmacokinetically friendly drug that's pharmacodynamically unfriendly. Basically, nitric oxide is bound to this iron moiety and surrounded by cyanide. If you use high doses of nipride, you'll often see issues like metabolic acidosis. But I think in renal failure in other patients, this potentially drug is problematic. And also, one of the things that occurs is when you use nipride, you make the patient often hypovolemic. Let me show you just sort of a quick example. This case is 20 years old, but I think important. The young man, 19 years old, who underwent a heart-lung transplant, he'd been living at 70, 80 systolic. He's postoperatively in the ICU with respiratory variation, trying to get his blood pressure back to 80 systolic. Start nipride at a low dose, right atrial pressure plummets, PAD plummets, blood pressure is sort of unstable, give him some colloids, and then restart sodium nitroprusside. One of the problems is it's sort of counterintuitive that why do we have to use volume when we're trying to use a vasodilator, and that's really part of the issue, in part, with IV nitroprusside. I've been interested in IV dihydropyridines. The first generation nifedipine, not used in this country, but nicardipine approved in '94, and clofidipine recently approved a couple years ago. These drugs are direct arterial vasodilators. I believe they have important applications in the ICU for managing both systemic hypertension, especially after neurosurgery, but also it's used in Europe for pregnancy-induced hypertension. Nicardipine was approved in 1994. Unlike diltiazem, which to me is an antiarrhythmic that has effects on vascular smooth muscle, these drugs are arterial-specific vasodilators that are pure arterial dilators. And let me just show you some of the early data that really illustrates to me the clean hemodynamic effects of these drugs. This was patients in the cath lab who had high mean blood pressures greater than 100. They gave a milligram of nicardipine over a minute, and look what happens. Mean pressure drops about 27 torr, no change in wedge, no change in right atrial pressure. Cardiac index goes up, LVDPD goes up about 10%, and ejection fraction goes up about 10% with no change in heart rate. So think about it. Keep preload constant, drop resistance, improve forward flow, no change in heart rate. And one of the advantages of these particular drugs is if you're hypovolemic, specifically following aortic valve surgery where you have LV hypertrophy and you have the issues of systemic vasoconstriction, nicardipine is a very useful drug in this setting for ease of administration and careful titration of the blood pressure. Clofidipine is a drug I worked with on 15 years. It's a potential replacement for nitroprusside, except it cost a lot more. It was removed from the market because of manufacturing issues and may resurface. I've received research report in the past for our work and haven't received in several years, and I have no conflicts of interest for this presentation besides this. Interestingly, of clofidipine, it was compared to nipride, nitroglycerin, and nicardipine, and it's one of the few studies that actually looks at mortality, MI, stroke, and renal dysfunction, and there is really no clinical difference in about 1,600 patients from data that was reported to the FDA and allowed for approval. In fact, there's a slight difference in mortality in the comparators versus sodium nitroprusside, versus clofidipine, but it was not statistically significant. So it's safe as well as effective as a therapeutic agent, and most of this data actually came from cardiac surgery. One of the things that when you pick a vasodilator, especially in our patients, especially after coronary surgery, is the risk for vascular spasm. I believe it's a real phenomenon. We've created a model. We studied reported about 8 to 10 reports in the literature using internal mammary arteries where we de-endothelialize them or activate them with thromboxane. And the bottom line, to sort of summarize 10 years of work, is the fact that when you have arterial vasoconstriction, only specific agents will vasodilate, and that is the dihydropyridines, the phosphodiesterase inhibitors like milrinone, papaverine, and the nitrovasodilators are the only drugs that will affect this and produce arterial vasodilation. So what we do every day, as I mentioned earlier, is we manage biventricular dysfunction, and we have, hopefully, a sweet spot for blood pressure control. Clearly, that sweet spot for adequate perfusion versus cardiac index, Dr. Kotz mentioned early with some of Dr. Kirkland's early work. But the bottom line is hypertension is bad in terms of bleeding and issues on cerebral perfusion, but also hypotension is bad as well. And that's sort of maintaining that yin-yang balance of adequate cardiac index and hemodynamic intervention is really the art form of what we do, maybe sometimes less than science. And one of my favorite quotes, as I studied French and lived in France for a while, is a great quote: "Doctors pour drugs of which they know little for disorders of which they know less into patients of which they know nothing." If you lived 300 years ago, you would be skeptical too, like the patients in Voltaire's time. But I think the science and the application of pharmacology is particularly important in managing biventricular dysfunction every day in terms of what we do. Understanding how and why drugs work is important, and hopefully optimizing pharmacologic therapy. You'll hear more about ventricular support, but I think that when pharmacology fails, we have the unique applications for balloon pumps and BIVADs and other aspects, but I think this provides a basis for our pharmacologic manipulation. Thank you so much.
Gerald, one quick question for